What inspires me the most in my new role as an independent infection preventionist consultant is in the field of preventing surgical site infections. I really enjoy working with surgeons and OR directors, infection preventionists, and other clinicians to really pull together multidisciplinary teams that can set up a surgical stewardship program in the pre-op, intra-op, post-op, and even home care phase so that we can get better patient outcomes and prevent surgical site infections. I do think that the clinical issue that's been underappreciated has been this topic. And I kind of have my own sense of why. I think about 10 years ago, we started to pull together bundled approaches to preventing healthcare-acquired infections. We started off with CLABSI, or central line associated infections, bundles for that in the intensive care units primarily. We also had VAP bundles, or ventilator-associated pneumonia bundles, again, primarily in the ICU. And then catheter-associated urinary tract infections, primarily not only the ICU, but on nursing units. So it was a little bit easier to put those kinds of programs together. But if you think about the topic of preventing surgical site infections, it involves pre-op, intra-op, post-op, and even home care. It involves surgeons, anesthesia, physician's assistants, residents and fellows, environmental services, plant operations. You've got so many different departments that are involved in that kind of a surgical stewardship program. So I think it's been a bit challenging for infection preventionists themselves to implement that. This requires teamwork, and I also feel that it really involves support from administration down, a very high level, either VP, CNO, or chief of surgery to be the champion of the team, and then have multiple task forces that do different pieces of the work and report that back to surgical stewardship, who then can report to the infection prevention committee, the surgical committees, as well as the environmental care committee on the teamwork that they're doing. So some of the key recommendations that I've come forward with as part of my experience in this field is in 7 different areas. And I actually set up a website called www.7sbundle.com, where we house the recommendations of the different 7 steps to the foundation to a surgical stewardship program. So the first step is to have a safe operating room. And that involves a lot of observational studies, evaluating practices and policies and procedures, making sure that you're implementing the National Patient Safety Goal, 070501, which has 24 elements, assuring that you're implementing the ARN evidence-based guidelines, as well as the new CDC guidelines over the last few years. We also have the American College of Surgeons and the WHO. So there are many different things that have to be looked at and evaluated in the operating room so that you can come away saying that is a safe OR and I would have surgery in that operating room. The second step involves screening. That you would screen your patients in the pre-admission testing process, not only for risk factors like diabetes, or cardiology consults or diabetic consults for A1Cs, but also screening for the presence of MRSA or MET-sensitive Staph aureus in the nasal passages. Now, this kind of a screening program has to be done at least 2 weeks ahead of time so that you can have those results available to then implement a decolonization protocol for patients who have either one of those organisms. And that typically involves 5 days before surgery, patients taking a CHG shower, as well as applying an antibiotic ointment called mupirocin twice a day to the nasal passages, or in some situations, some are using a nasal antiseptic that has alcohol or iodophor with it. Then we have the third step in the process of showers, that patients are taking a pre-op shower the night before surgery and the morning of, preferably with the CHG product because that has a residual bacterial buildup on the skin, or soap and water if that's not available. The fourth step is alcohol-based skin antiseptics. There's a chlorhexidine alcohol product as well as iodophor alcohol products that can be used to sort of replace just using an antiseptic solution like betadine, iodophor solution. The fifth step is the whole topic of surgical irrigation. The evidence has not shown that using an antibiotic irrigant reduces SSIs. And so there's a lot of work now kind of in the field of antiseptic irrigations. There is a chlorhexidine irrigant, very small amount, 0.05% chlorhexidine that can be used, as well as iodophor is another irrigant that can be used rather than use antibiotics. The next step would be antimicrobial sutures. Those are recommended by the American College of Surgeons, the WHO, and the CDC. There is enough evidence in 13 meta-analysis showing approximately about a 30% reduction in SSIs with the use of antimicrobial impregnated sutures. And then the last step is the whole topic of the incision, skin adhesives, or some type of a post-op dressing in the post-op period to give it protection when they go home. So skin adhesives will seal the incision together, almost like a crazy glue, and give it 7 days of wound healing strength. There's also available a mesh, especially good for long incisions, and then they can put the topical skin adhesive on top of that mesh. There's also a CHG impregnated dressing that they can visualize the incision, and that can be left in place for a good week or so post-operatively. And there are even silver products. So what I have found in the work I've done in this area, you want to involve your clinical educators and your wound care specialists and the surgeons and the PAs and the residents on the whole topic of post-op dressings. So that's the foundation to the 7S bundle. You can also add in other components of, for instance, a colorectal bundle, an abdominal hysterectomy bundle, a C-section bundle, but at least have a foundation to your program that we call surgical stewardship.